Welcome to AETCM. Today we're going to discuss a case about one 15-year-old male who was brought in our ER with history of accidental intake of acid cleaner 3 days back. So shall we begin? Sir?
Okay.
Sir, in initial assessment, patient was conscious, oriented and able to complete one full sentence.
Okay.
Airway was patent, no secretions were noted.
Okay.
And breathing but respiratory rate, air entry was bilaterally equal, respiratory of 22 per minute and saturation of 96% was maintained in room air. In circulation, BP of 140 over 80 mm Hg with pulse rate of 82 per minute and all peripheral pulses were palpable. Sir, and disability, GCS was full with and pupil was bilaterally equal. And exposure was temperature was febrile and
He was febrile.
febrile,
Okay.
yeah.
Okay.
And patient was exposed and further later covered to prevent hypothermia.
Hypothermia. Okay. So let's wait. So we have a 59-year-old male who had come with an ingestion of an unknown liquid. Probably you said it's an acid cleaner. Okay. So what are the key points that you should know when somebody is drinking and coming for like an acid ingestion coming to the ED? What are the key history that you should get from here?
So acid test in acid injury. If at all there is acid injury, acid intake, the patient can have the burns or
Okay, that's all fine. That all we can have. So my question is, what are the questions that you need to ask to the patient?
One thing is what type of thing that is ingested.
Okay, so he said it's an acid cleaner. So it can be anything. It can be a caustic ingestion, any caustic. It can be alkali or an acid. So it doesn't matter. So because all the mechanism of injury is a little bit different, but the problem that is created is equally the same.
Second is concentration.
Concentration, okay.
And third, duration of contact.
Duration of contact, and more importantly, when he had consumed it. That's a very important thing, because when the patient is coming immediately after ingestion and 4 days or 5 days after ingestion is very significant. So our treatment, everything depends upon when the patient is presenting to us after the ingestion. And also it is very much important thing whether it is an accidental or it's an intentional. So it can be an intentional for a suicide, or in a pediatric child they can, as in this case also, they can accidentally, so they just take 1 or 2 gulps after seeing that this is not what he was intended to, they will just throw it away. So that part is very important. So that history is very important. If it is intentional, what is the difference? They will be drinking more amount. They definitely wanted to harm themselves. So they will be drinking a lot of increased amount. So other one, they will just take 1 or 2 gulps, and after that they will know that they have taken something that is not intended and they will just spit it out. So that is the difference. And time of ingestion, why it is important?
As the time prolongs, more of the injury will occur, including perforation.
Okay. See, again, the complications that you will anticipate will be different at the different time presentation. And also, when the patient is consuming, you will have oral ulcerations, oral injury, and further on to, you will have tracheal injury. Sometimes they can aspirate into the lungs. Also, to the GI system, there can be injury. So, the most common one, if they are drinking this, so it will be GI injury. If you wanted to do an endoscopy, we should be doing it very early, within 12 to 24 hours. If we really wanted to know the extent of injury, the grading of injury, you have to grade them between grade 1, grade 2A, grade 2B and grade 3. All this injury grading, if you wanted to do an endoscopy, it has to be done early. So within 24 hours only you can do, or we have to wait for another 5 to 7 days. Only after that we should be going for an endoscopy. Sometimes some people recommend to do it after 2 weeks also. So if you are not doing it within the first 24 hours, then your endoscopy you'll be doing only after few days. So maybe after developing some complication, maybe already the structure would have developed. We only during that time we will be doing an endoscopy. So this information is very key. So the time duration of ingestion when the patient has consumed the acid or alkali or whatever it is, that information is very key. Okay, so the patient has come to you. How many days after ingestion?
After 3 days.
3 days after ingestion. So 3 days after ingestion. So already the complications would have set in, right? Already the complications would have set in. So let's see, within like 30 to 40 minutes, within 1 hour he is coming to you. What will be the expected clinical presentation during that time?
Patient
Initially, soon after ingestion.
abdominal discomfort, vomiting, then burping.
They will be complaining more of the exposure site problems. They will not be having more of the complication. They will be initially, maybe for an acid or an alkali, they will have burning sensation over the oral cavity. Maybe the tongue would have got swollen up, and they would have tracheal, they have difficulty in swallowing, and maybe nausea, vomiting, maybe little bit after some time. So that is how they will present. And if they have aspirated it or they have inhaled it, it has gone into the lungs, they can come with breathing difficulty and all those complications. So they can hemoptysis, hematemesis, that is like after maybe within 6 to 8 hours, 24 hours to 48 hours, they can come with all the probable complications. So this is what you need to see. So this patient is coming to you after 3 days. So what are the problems that you can anticipate in him?
After 3 days, there is a high chance that this acid can cause severe burns, including ulcers and even perforation in the esophagus and also in the gastric region. It can cause, if at all the acid went into the airway, it can cause pneumonia,
chemical pneumonitis.
Then,
so 3 days we are expecting local injury would have happened, and it would have maybe the inflammation phase would have slowly settling down. But when you look into the GI tract, it will be more of ulceration, and chance of complications like perforation, everything is going to be very high. And also, as you said, the patient would have aspirated to the trachea, and further damage to the tracheal tree as well as chemical pneumonitis chances are very high. And next thing, locally also the skin burns can happen if it has spilled over to his skin. So locally the skin burns, all those skin, because of the local exposure also is a possibility. And sometimes if there is something like an alkali ingestion, certain alkali, they can cause hypocalcemia. So hypocalcemia, they can have this hypocalcemia related problems, and maybe they will have recurrent vomiting, so they will have metabolic alkalosis. So these complications is what we are expecting for him right now. So we can have local complications, we can have GI related complications, we can have tracheal airway related complications, and we can have electrolyte disturbances. So these are the important things that we need to discuss at this point of time. Okay, so his airway was patent at this present. So he was, whether any airway securing was done for him before referring coming to here?
Before coming here, the patient had severe respiratory distress. On the day of the ingestion of...
On the day of ingestion, he has severe respiratory distress. Okay.
And further intubation, outside intubation and ventilation was done.
Okay. So suppose this patient you are attending in the ED. So you said the patient had respiratory distress. So how will you plan your intubation for a patient like with acid ingestion?
So
you have to tell me what is the ideal thing to be done. What are the possible things? What are the possible anticipated complications also?
Thing is that as it is an acid ingestion, the whole airway, including the mouth, will be the whole skin will be edematous, and there is high chance of during the intubation also the skin can peel off.
Okay, so one thing is that the tongue itself can be swollen up. So visibility, visualization will be difficult. There can be glottic edema, and surrounding area there can be profuse bleeding. And when we are doing the laryngoscopy with a direct laryngoscope, there is a high chance that while just touching the tongue, it can start bleeding. So that is a big problem for this group of patients. So we have to be gentle as possible. But ideally for this group of patients, it should be fiber optic intubation. So that is the ideal thing to be done. It should be as gentle as possible. You should do an fibro optic guided, very clearly you have to see very smoothly, then we have to intubate. That is the ideal thing to be done for this group of patients. But if you don't have facility, whatever you are doing rapid sequence intubation, you have to keep all those things in your mind. So the airway edema will be there. So there is a chance that you need to use a smaller size tube. So glottis, if you are having like an adult patient, you want to use an 8.5, but sometimes you need to put in a 7 size tube. So all those things you need to keep in mind. So fiber optic intubation is the ideal thing for this group of patients when they have gotten probable airway injury and you are planning to intubate this patient. Ideally will be that. So that thing that you should keep in mind. Then respiratory distress. He had respiratory distress, so they intubated him. Okay, then
further following the intubation, he also developed decreased urine output.
Okay.
And also creatinine values raised up to 7.
Okay, what will be the reason for renal failure in this patient? What would be the reason?
That
What could be the reason for a renal failure in this patient?
Dehydration, pre-renal cause.
Pre-renal, why pre-renal cause? Till what day he went to the hospital?
same day.
Same day he went to the hospital and he had a respiratory distress and he was intubated. So what could be the reason why he had a renal failure?
Similar to burns.
Okay.
Rhabdomyolysis.
Similar to burns, you can have rhabdomyolysis sometimes and you can have dehydration also a possibility. Any toxins, any of this alkali can cause direct injury to the kidney?
Potassium.
Post.
Usually no, but they can have something can like calcium oxalate crystals they can cause and they can get precipitated. So that is the only thing. Some acids, I don't remember exactly the name. So they can cause this precipitation, but that is not an acute renal failure, maybe after 3-4 days. Not initially like soon he developed. Maybe he would have an underlying some CKD might be there. On top of that, it got suddenly worsened, or it can be a pre-renal, sudden pre-renal, or a direct acute kidney injury related maybe secondary to hypotension. We don't know exactly what is the reason. So, what was done for him? He was dialyzed there.
He was not dialyzed. Other parameters were
Within normal limits. He had good urine output, so they just conservatively managed initially.
Further decrease urine output, then urine output came out to be normal.
So, when you are having such a patient, what is the other thing that you need to consider? He has taken some liquid and he has gone into a renal failure.
IV fluids.
No. What are the problem? What are the other possibilities that you need to consider? We are just thinking in terms of an acid.
Co-injection.
There can be co-ingestion. That is the one thing that you need to consider. He is giving a history that it was an unintentional. It was an accidental one. But usually, if it is a suicidal one, they can mix it with alcohol. So, toxic alcohol, associated toxic alcohol ingestion can be a possibility. We don't know whether he has consumed any toxic alcohol along with this or even normal alcohol. For time being, it can cause just metabolic acidosis. So, we always need to consider whether there is any co-ingestion. So, we can't just take up of the fact that this patient has taken only this. So, co-ingestion also we need to keep in our mind. Okay. So he was intubated there for respiratory distress. Then he had renal failure, which was conservatively managed. And third day he was shifted here. After he was extubated.
Extubation was also done from
Outside hospital.
itself.
Okay, so he was extubated and referred to us.
Yeah.
So why he came to our hospital now?
Because patient was initially he had abdominal pain, vomiting, and all. After extubation also he was still having persisting abdominal pain associated with guarding and rigidity.
Okay.
So they referred here for further evaluation of the same.
So again we'll come back to this patient again. Now he was intubated initially for respiratory distress. So they stabilized him. And once he stabilized, he was referred here for further management and he was extubated. So his airway part was taken care. Airway and breathing is fine. So he was extubated and he was brought in because of abdominal pain. So that is his basic problem right now. So how will you proceed now?
So
This patient A, B, C is fine. Right now. So he still have an abdominal pain. So how will you proceed?
So for abdominal pain, you have to initially correct the pain management should be done.
Okay.
IV analgesics can be given,
Okay.
including opioids.
Okay.
Then later on, we have to know why is he having the symptoms. So CT abdomen.
For that, we have to find out the bowel and bladder
Movement. So we can just do a simple thing is that we have to first keep him NPO. That is the first thing that we can do. Correct all the electrolytes. Whatever electrolyte abnormalities, vomiting is there, you correct the electrolytes. Put him on an IV fluids. So start him on an IV fluid. So you have to maintain here the nutrition part also has to be taken care. Also the electrolyte disturbance also has to be taken care. So the next thing what you need to do, you need to look in why he is having this abdominal pain. So it's a simple thing. So what could be the reason? We straight away know it can be a perforation. So before going for a CT, you can just take a chest X-ray and see. He was extubated. You can just shift him. He's off O2. You can just shift him and get an erect X-ray and see whether there is any gas in the diaphragm. If there is a gas in the diaphragm, you are very clear this patient has got a perforation. So that is the only thing that is needed. Then later you can do a bedside ultrasound. All those things can be done to look for any features of peritonitis. Then you don't get an answer why he is having. Then you can look in for other causes by taking a CT. Whether any chance of pancreatitis here? Yes. He can develop pancreatitis also. That can be attributable to his abdominal pain. So we have to keep all those things. You start with the simple investigations. It can be part of his complication. So it can be a perforation, the simple esophageal perforation, or it can be a lower down duodenal perforation or a gastric perforation. So usually it will be more in the gastric or in the duodenal region, the perforation will be seen. So we have to see all those things. So then if not settling, then you take a CT. So that is how you need to look into. Okay, then continue. So he was kept NPO and he was pain management was done and
fluid correction and
what was the CT was done for him?
Outside they had already done a CT,
Okay.
which was showing dilated wall of dilated and edematous wall of fundus and body of stomach.
Dilated body of fundus. Okay,
yeah.
edematous.
Yeah.
Okay.
And also CT neck was also done, which was showing edematous upper thoracic esophagus.
Okay.
Yeah, from
That was the only findings
which was from the
outside hospital. Okay.
From our hospital, we initially went with a X-ray chest, which was showing bilateral patchy infiltrates was noted.
Okay.
Then
it was noted. Bilateral infiltrates was there. Okay.
Then further we did a USG abdomen was done, bedside abdomen was done, which was not minimal ascitic collection was.
Minimum free fluid in the abdomen. Why is having free fluid in the abdomen? It can be part of your inflammation. So all the organs, you have all the stomach, you have the intestine, everything inflammation, or it can be part of perforation also. It can be a concealed perforation. We are not sure. But outside CT, anyways, it's not showing any perforation at this point of time. So maybe perforation is out. Maybe due to the inflammation, whatever he had, he might be having this free fluid in the abdomen. Then
later on, we did the lab parameters was also sent. In which lipase and amylase came out to elevated, lipase of 696 and amylase of 500.
Okay.
And total counts and other
everything was elevated. Okay. What was the CRP?
CRP of 50 and procal of 20 was.
Okay. So he would have developed an additional bacterial infection also. He was there in the hospital for 3 days. On top of this, he has developed a bacterial infection also. So that could be the reason why there is an elevated procal. Or usually the procalcitonin, 20 procalcitonin elevation is attributable to a bacterial sepsis. So unless and until it's proven, it's a bacterial sepsis. So he had developed into a complications of whatever has happened. He had an ingestion. So maybe primarily he went to a chemical pneumonitis. Now he would have gone into a more of a pneumonia sort of a picture. That is why he is having an elevated procal. But right now his airway and breathing is maintained and he has an minimum edema of the stomach and the duodenum. So that is the only finding. So what are the key things when you have an acid ingestion in ED? What are the things that you should do? What are the things you should not do? What are the key things that you need to remember whenever a child or an adult patient is coming to the ED with a history of ingestion like this? You being an emergency physician, what are the things that you should do? What are the things you should not do?
First one is personal protective.
First one, personal protective equipments. Okay.
Second, no gastric. It's contraindicated.
No decontamination. We can just put one word and finish it off. There is no role for GI decontamination. Rather, maybe role for surface decontamination. If there is some spillage over the skin, over the eyes, we need to do surface decontamination. But there is no role for GI contamination. It's absolutely contraindicated. No role for your activated charcoal. So that is the next thing. No role for your activated charcoal. So these things you need to always keep in mind. Then next thing.
Expose and see any external injuries.
Yes. Then.
Any caustic marks.
Okay.
Then.
Remove all clothing.
Remove all clothing. Okay, fine. So the thing is that when the patient comes to you after an ingestion like this, it is just like our inhalational injuries. So initially they will look quite okay, but suddenly they will start deteriorating. So once we start trying to intubate at that point of time, it will be difficult. So if you anticipate an problem with the airway, go ahead and intubate. Maybe hoarseness of voice. You're just getting an hoarseness of voice. The patient itself is complaining, my voice has changed. So that will be the initial clue, just like in our inhalational injury. So that is just the glottic edema that is getting developed, and the patient has slowly started to getting into have a mild stridor, and all those things, just immediately go ahead and intubate him. So that will be the ideal thing, and always I said fiber optic intubation will be ideal in this group of patients. Then
Medical analgesia.
IV.
Analgesia, pain management, very, very important because they will have significant pain. There is any role for neutralizing agent?
No.
No.
So that is again one myth that if you patient consume acid, you give alkali. So it is going to double the issue only. So that is totally not needed at all. So only thing, avoid decontamination, more of symptomatic management and manage the complications as at when it develops. So we can't any role for steroids. Previously there was a lot of indication that you give steroid to prevent strictures. Right now there is no indication to give steroids.
No antiemetics also.
No antiemetics in the sense you can give centrally acting. You can have centrally acting one, but prokinetic agent you can avoid. But you can have centrally acting like ondansetron. You can give that. There is no issue. Pantoprazole you can give. You need to start him when you will start feeding. That is the next question. So he is in the ED. So when you will start feeding him.
Probably we keep the first 20 to 24 to 40 hours NPO.
Okay.
After that we start with oral this thing, soft diet.
Soft diet. You can start with some liquid diet. For the first 24 to 48 hours, it's better to keep them NPO. We don't know what extent the burn has occurred and what the patient had happened to him. So just keep 24 to 48 hours and see with the clear liquids how the patient is tolerating. If the patient is tolerating well and good, you can continue with it. So that is again role of endoscopy. If you're doing, do it early within 24 hours. If you want to assess why you want to do an endoscopy, to understand how the depth of the ulcer. If there is a grade 2, grade 3, grade 2B and grade 3 ulcers, you are able to see, then you are anticipating a stricture later on. So you need to, you can brief the bystander regarding what is going to happen. So that is the only advantage of doing an early endoscopy. And if the patient developed with a grade 3 ulcer, he is developing an abdominal pain, that okay, we know that this area there is a problem, so we can easily treat that area. If there is a perforation there, okay, the perforation would have happened from this area. So you'll get an idea regarding that. So that is the only reason for an early endoscopy. But if you're not able to do it on a later day, maybe after 5 to 7 or even after 14 days. So that is the indication for an endoscopy. Most importantly, treat the complications. Treat the complications and electrolytes correction. All the electrolytes, you have to be very specific. Metabolic alkalosis can be associated and there can be hypocalcemia, as I said, in certain oxalic acid ingestion. That is what I want to do. Oxalic acid is an antifreeze. Oxalic acid ingestion, you need to give this thing. So that's it. In
Resuscitation
fluid resuscitation.
and antibiotics to prevent secondary
Infections.
If at all we are suspecting any.
So ideally it will be balanced fluids. You can give balanced fluid rather than normal saline. You can either go for a ringer lactate or any of the other agents. Okay. Any other points you have to add on?
We can also go for CT instead of like this. Endoscopy is not possible.
Possible. You can go ahead
They
for
also have
CT.
a grading system. So anything about 1, like 2 or above, and also this endoscopy grading more than 2B or above is warrant at least 1 week of observation in the hospital. To like follow for perforation.
Follow perfect. So there is a high risk group of, you can grade the risk of the patient. Okay. Fine. Anything else? Okay. How is the patient now?
Patient, as the creatinine value was elevated,
Okay.
CCT was not done.
Okay.
Plain CT abdomen was done, which was showing focal dilatation of D2 segment with mesocolic fast stranding, and also jejunum was mildly dilated. And bilateral mild pleural effusion was also
Okay.
noted. So in CT neck was also done, which was showing swollen and edematous epiglottis and hypopharyngeal valves. So patient is right now kept in observation, and
He's taking oral feeds, liquid diet.
liquid diet started.
Okay. Fine. Thank you.